All right, Madam Chairman, you may begin.
Thank you, Dylan. I thank you, and thank you, IS, for your work. Welcome to the Public Health and Minority Health Disparities Subcommittee. Today, we hold our first virtual briefing in this subcommittee history. I ask for your patience if we encounter any technological streaming issues. Before we begin, I remind subcommittee members that this briefing is being streamed on the Maryland General Assembly's YouTube channel. Subcommittee members will be muted throughout this briefing. If you have a question after each presentation, type question in all capital letters in the chat box on the right side of your window. I will call on the delegates to ask questions. After I call your name, please wait a moment while Dylan unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel. Now, one question and one answer from each individual panelist. Also, please keep your question shorter than the expected answer. Today, the Public Health and Minority Health Subcommittee hears from a variety of agencies and organizations about the impact of COVID-19 on racial disparities in Maryland. First, 19 health disparities. We'll hear from Dr. Sharita Hill-Golden, who has been an amazing partner, from the Hugh P. McCormick Family Professor of Endocrinology and Metabolism and Vice President and Chief Diversity Officer at Johns Hopkins Medicine. This presentation will be followed by a question and answer session. In our second panel, we'll hear from Dr. Nalish Kalinadarman, and he's actually works for the Anne Arundel County Health Officer. He does great work in Anne Arundel County and an amazing partner. He will discuss COVID-19 in Anne Arundel County and local outreach efforts. This presentation also will be followed by questions and answers. Finally, we'll hear from Dr. Jeeleen Chen, who's the Acting Deputy Secretary of Public Health Services at the Maryland Department of Health, and Dr. Noel Braithwaite, who's the Director of the Office of Minority Health and Health Disparities. They will provide an overview of COVID-19 racial and ethnic data collection and state outreach efforts. And again, you'll be able to ask questions. Please keep in mind that this briefing is scheduled to conclude by 3 p.m. and perhaps even earlier than that, because I know some of you have some commitments. So we're going to get started. Can we have the first panel, please? Thank you.
All right, Dr. Golden, I'm pulling up your PowerPoint.
Okay, great.
You may begin.
All right, so good afternoon. I first want to thank Chairman Pena for inviting me to your subcommittee meeting and to talk to you about COVID-19 and health disparities and how we've been responding at Johns Hopkins Medicine. So next slide. So, for me as a physician, this is my favorite quote of Dr. Martin Luther King Jr.'s, and it says that of all forms of inequality, injustice in healthcare is the most shocking and inhumane. Next slide. And so as I've considered that quote and thought about the things that I learned in medical school, it's been really important for me to understand sort of the medical history in our country and how is it that we got to the health disparities that we see in a variety of conditions. And so it's really important to think about the historical context of this, both the medical and scientific contributors, as well as the social conditions and policies. So we know that there were practices that started during slavery and continued into the post-Civil War era, and that included experimentation on vulnerable groups without their consent. So initially, there was experimentation on slave women without their consent. So Dr. Mario Sims, who's considered the father of modern day gynecologic surgery, performed many of his procedures on and perfected them on slave women without their consent and without general anesthesia. And so, those practices of doing research and developing medical procedures on marginalized communities continued, to include those with disabilities, those who were institutionalized, et cetera. And so that's an important part of our medical and scientific history to recognize. In addition, there was a eugenics theory that was really perpetuated at the turn of the last century that essentially stated that certain race ethnic groups were biologically inferior to others. And so that started with including African Americans, but then was expanded to other groups. So immigrants who were new to the United States, those who were Latinx, those who were Jewish, those who were Southern Italian immigrants, those who were from Eastern Europe. And so this sort of created this caste system, as you will. And while we know that eugenics theory really has no scientific foundation today, that there are still those biases in thinking about minority patients when they come into our healthcare system. And then there was also the Flexner report that was published in 1910, and that led to the closure of many medical schools in the United States because it converted medical school from being proprietary to using the biomedical model. But what that meant for medical schools that were educating Black physicians in the US is that after the Flexner report was published, there were only two that remained open, and that was Howard and Meharry. And that was at a time where those physicians, aspiring physicians, could not gain access to predominantly white institutions. So what that means is that we've had a dearth of African-American physicians to care for the population in the country that's diversifying. And there was a recent study published last month that showed that if those medical schools that were closed had remained open, there'd be at least 29,000 more Black physicians today than there currently are. So it had a huge impact. And so what that's resulted in is that many communities, minority communities, have a lack of trust in the medical establishment because of the history of the eugenics theory and the experimentation. There are also language and communication barriers between clinicians and marginalized communities. And then there's also residual healthcare provider bias toward minority patients. So there is a myth that African Americans are more pain tolerant, and that's actually not true, but in fact, their pain medication needs are not as well controlled in the hospital because there's this biased history of the experimentation that occurred without anesthesia. And so this was what the doctors back then had to tell themselves to justify what they were doing. So what that's resulted in is that in the healthcare context, many of these communities have poor access to care. They have a decreased quality of care. They have less participatory decision-making in the patient-provider relationship, and reduced health literacy that increases their risk for disease. But then it's also important to think about the social conditions and policies. And so we know that redlining practices that occurred in major cities and actually started in Baltimore City where I work, and the predatory lending practices that resulted led to racial residential segregation and housing insecurity. So once those neighborhoods were redlined, then that meant there was a lack of investment in the schools in those neighborhoods, the public works, and economic investment. And so consequently, we now have neighborhoods that have the residual of that now sort of define the social determinants of health that we see. And so that's led to structural and institutional racism, resulting in neighborhoods with decreased walkability and cleanliness, decreased open green spaces, a lack of access to healthy food, and a lack of access to affordable housing. So all of those things influence patients' health behaviors that increase their risk for disease. And then as we thought more specifically about COVID and why is it that diseases like diabetes, heart disease, and asthma are more linked to COVID, that's because that these same populations are exposed to poverty. They're often living in crowded multi-generational housing. There's been the mass incarceration, particularly of Black and Latino men. There's also increase of these communities in the service sector, and they were considered essential during the pandemic. So they often had to go in using public transportation at a time early on in the pandemic when there was inadequate PPE. So they've actually had increased exposure to COVID-19. So this has led to the disparate outcomes that we're seeing for those who already were at risk for chronic disease. It now makes their outcomes with COVID worse. Next slide. So I think it's important to understand that context because then we can think about what can we do? What should be our public health and health system strategies to support our communities? Next slide. So one of the important things, and this was work recommended by the Rainbow Push Coalition and the National Medical Association, is that we need to engage in prevention via innovative civil rights and public health campaigns. And so I think it's really important for health systems to partner with trusted community messengers. And so this is an example of a partnership that, that we did with Reverend Kobe Little, who's the president of the Baltimore chapter of the NAACP. And this sound truck was funded to drive through neighborhoods where people were not socially distancing in the spring with the key public health messages. And it was communicated by local Baltimore celebrities that the community could identify with. Next slide. And another important thing is around our data. And so really having required collection and public reporting of our COVID-19 testing, emergency department visits, hospitalizations, and outcomes data, stratified by race, ethnicity, and gender, as well as language and 9-digit zip code, which links to the census tract. And I think we're going to hear more about that later on in the session, but this is particularly important. And I was speaking with two of the leaders of our Native American Center in the Johns Hopkins Bloomberg School of Public Health. And, right now they're still in other category. And so there are parts of our Maryland constituents that we are not adequately capturing. And so we really need the full array of race and ethnic categorizations. And then it's important to collaborate with our state health systems to ensure the accurate collection of high quality, self-identified race, ethnicity, and language data. Next slide. And so there is a House bill that's being considered at the federal level on equitable data collection. It's called the Equitable Data Collection and Disclosure on COVID-19 Act. And that would provide funding for data modernization and quality improvement in that collection, both nationally and locally. And this will have benefits beyond COVID. Next slide. Then it's also important to expand testing access, so timely access to COVID-19 testing stations and prioritizing testing in medically underserved areas and those with transportation limitations. So many of our patients at Johns Hopkins Medicine really don't have cars to access some of the testing sites that have been set up. So it really becomes important to set them up in the community and to disseminate that testing information widely using multilingual, culturally sensitive public service announcements. In the communities where this is most relevant are the African American, Latinx, and American Indian and Alaska Native communities. Next slide. And so this is an example of a partnership that we did with Build, and we partnered with Bishop Bruce Lewandowski and Robert English and Build to stand up a COVID-19 mobile testing center in our 21224 zip code, which is one of our Baltimore City hotspots. And so we have been operating there on the parking lot of Sacred Heart Church of Jesus since the end of June. Our positivity rate had been as high as 40%. And then the last 2 weeks, it's finally come down to the teens at about 14 or 16%, but still a lot higher than in the other. And so we've also been able to use that site to connect those who come in for testing to community resources. Next slide. And then it's also important to protect our care providers. And so not just the physicians and the nurses, but there are a lot of other individuals that need personal protective equipment who perform support duties in hospitals as well as nursing homes. So those involved in patient transportation, environmental services, food services, maintenance staff, patient care assistants, and aides and technicians. They're all at the same risk that our physicians and nurses are. So everyone needs to have adequate PPE. And in addition, those who are patrons and staff at homeless shelters also need adequate PPE as well as soaps and hand sanitizer for proper sanitation. Next slide. And so these are, again, some legislation that's currently being considered at the national level. So we want to continue to ensure full implementation of the CARES Act provision, which allows for no cost for screening and treatment for COVID and related conditions. It also includes follow-up of many of the worsening medical conditions that are being unmasked in the setting of COVID. And there is a support, health, and economic recovery ombudsman emergency solution that would help to, or the Heroes of 2020 bill that's being considered to expand the CARES provision. It's also important to depopulate our jails and improve the PPE for prisoners and prison workers. And just to really give you a perspective on how many people we have incarcerated in our country, we account for 4% of the world's population as a whole in the United States, but we account for 21% of the world's incarcerated population. And really, you know, out of the millions of people in jail, it's really a small handful that are in there for criminal offenses. And so at a time where, you know, we can have more rapid spread, this becomes an important initiative. Another bill being considered at the federal level to support vulnerable communities is the Community Solutions for COVID-19 Act. And that would allocate $1.5 billion over the next 3 years for community organizations who are responding to the pandemic. So like some of the community organizations that we at Johns Hopkins Medicine have worked with. Next slide. So in terms of other legislation, there is a COVID-19 Race and Ethnic Disparities Task Force Act of 2020, which would really assemble a task force to provide weekly medical supply allocation recommendations to FEMA. You all are probably familiar with the remdesivir story and how that's sort of been distributed. You know, soon it will be vaccines, hopefully. So we need to really figure out how is this being executed to really oversee and influence the federal response on health equity in this pandemic. And then there's also the Health Equity and Accountability Act of 2020, which is a comprehensive policy framework necessary for funding to close the health gaps that we're seeing. Next slide. So a couple of the things that we've done at Johns Hopkins Medicine that are important, we thought that it was really important in our scarce allocation of resources framework to ensure that that had a health equity lens. And so we added specific anti-discrimination language around social characteristics. We removed age from our scoring criteria and our algorithm. We've also incorporated disability-specific principles by avoiding reallocation of ventilators that individuals for disabilities who are chronically vent dependent, you know, really depend on. And then for allowing caregiver support in the hospital to assist with communication. And we actually recently received a letter from the disability advocacy groups. And so we're spelling this out more specifically, but this is certainly already in our framework. We completed unconscious bias training for our triage and secondary review teams for this framework. And then we've also literacy adapted our patient handouts for the various triage review scenarios and translated them into our 5 most common languages in our health system. Next slide. We've also had a multi-pronged approach to supporting our Latinx community. So in addition to the community testing that I mentioned, Tina Tolson, who is our Senior Director of Language Services, expanded all language and technology services in our health system during the pandemic. Their team has provided access to over 220 translated COVID-19 documents. Dr. Kathleen Page, who's one of our associate professors in the School of Medicine, established Juntos, which means together. And this is a team of volunteer bilingual clinicians to facilitate the more complex communications with patients and their families that we were seeing in COVID. And so we've seen over 200 consults, and we've gotten buy-in from our leadership to at least continue to support this program over the next year as we anticipate a second surge. Central Soul and Kathleen and her team have also been supporting the Baltimore City Health Department with bilingual contact tracers, ED testing, follow-up, and meal delivery. So this is sort of the community support component we mentioned. And she's been doing weekly bilingual Ask Your Doctor segments on Facebook Live sessions. And I also want to mention Inez Stewart, who is our Senior Vice President for Human Resources, has been the executive co-champion with me in supporting these efforts. Next slide. We also supported our staff in standing up an emergency food pantry because food insecurity became an issue for our own staff. And so we thought that our staff is a part of our vulnerable communities that we should support. We ran this from the early April through the end of July. And at least between Johns Hopkins Hospital and Bayview, we distributed over 60,000 pounds of food to our employees and over 600 boxes of fresh produce. And there were also food pantries stood up at Sibley Memorial Hospital and also our hospital, All Children's down in Florida. So this was a system-wide effort. Next slide. And then we are really have been looking at how we can continue our health system and community partnerships. And so our office has been on Alicia Wilson's COVID-19 Anchor Strategy Work Group, which has helped to provide community support during COVID. And I know that their team has distributed over 1 million meals to the community in Baltimore City, as well as about 80,000 masks as well. And then I've worked very closely with Nikki McCann, who's our Vice President for Payer and Provider Transformation, as a part of the Baltimore Public-Private Partnership. So a lot of the work that we've done for the city of Baltimore in particular, and also elevating things to the state, have been through that vulnerable work groups work stream. So next slide. And then finally, I think it's important to address the critical shortage of underrepresented health professionals. I'm an endocrinologist by clinical training. There are only about 4% of endocrinologists in the country that are African American, even though this disease disproportionately impacts Black and Brown communities. And so that led me a year ago to shift my sort of administrative clinical operations and scholarship focus from strictly focusing on diabetes and endocrinology to focusing on diversity, inclusion, and health equity. I think this is probably my last slide coming up. So this is very important to me personally. I am a Marylander, a very proud Marylander. I grew up in Prince George's County, Maryland. My parents still live there, and they're in their mid-80s. And so whatever we're doing at the state level not only impacts sort of the patients that we see at Johns Hopkins Medicine, but also my family very directly. I'm a proud Terrapin as well. I graduated from the University of Maryland, College Park. And so all of my sorority sisters, half of them seen in that slide, still live in Prince George's County. And, and COVID has actually directly impacted our family. So I thank you for your attention on my last slide, and I'd be happy to take any questions.
Thank you, Dr. Hill Golden. I really appreciate your presentation and your work and your efforts. Are there any questions from the committee? Delegate Johnson?
Thank you, Madam Chair.
My pleasure.
Panelists for coming to speak with us today. I had a question on the community testing, where you set up in the community and did the testing in the hospital. You said at one time it was 40%. Was contact tracing that went with that? And if so, how effective was the contact tracing?
Yeah, so that's a good question. So there was contact tracing, and one of the things that has been helpful is that for those in the 21224 zip code, a lot of them go to Sacred Heart as one of their sort of safe havens in the community, if you will. And so Father Bruce has actually trained, many of his congregation have been trained as bilingual contact tracers. And so that actually helped when results came back to be able to use those individuals to help with the contact tracing. Because you're right, that's a critical element to slowing the spread. So that's how that was facilitated. And so with the testing, we were using our Hopkins excess testing capacity. So essentially through Sacred Heart, they would register, people could register, so we could get them into our system, so we could get the results back within 24 hours, because a lot of people needed a fairly quick turnaround. And so that's sort of how we facilitated. We were able to use our clinical operations, but like out in the community.
All right, thank you.
Thank you. Next, we have Delegate Lewis.
Thank you, Madam Chair.
My pleasure.
Thank you, Dr. Golden. I really appreciated your presentation.
Thank you.
It just so happens that I live in the 21224 zip code in the clinical care shed.
Okay.
Hopkins.
Okay.
I also wanted to share that I have benefited from the Hopkins mobile test site at Sacred Heart. I went there and got COVID tested. I was really amazed and pleased. My results came back in 18 hours. You guys are doing a great job. I've also participated, or I helped a little bit in one of the food distribution activities with the Food for Hopkins. So thank you guys for all you do. My question is about contact tracing coverage. Delegate Johnson asked about how that's rolling out, but my question has to do with the ability of your systems to actually make contact with a person who tested positive. How many of those people are you reaching? And the follow-up question, if you reach them, are you able to, how frequently are you able to secure quarantine housing for them, like we have at Lord Baltimore Hotel?
Yeah, so that's an excellent question. So, so one of the things that we're thinking about now, so, it's interesting, when we first were setting up testing, a lot of our staff had been redeployed from their original positions to sort of support our COVID efforts. And now, even in a second surge, we need to figure out how do we maintain non-COVID operations and COVID operations simultaneously. So, one of the things that will be important is we've been partnering with Baltimore City to assist with the contact tracing. And so Alejandra, who works with Central Soul and with Dr. Page, has been helping support the city in some of the contact tracing, but we need a lot more bilingual contact tracers. Because I think that when you're speaking to people in their language, it's about the trust. And so one of the reasons that the Latinx community, and particularly our immigrant members of that community, they are very uncomfortable with the contact tracing concept because, they're concerned that, you're going to you may actually use my information and turn me over to immigration. And so that's why, the idea of can we sort of help boost that contact tracing by having bilingual contact tracers in the health department, as well as those in the community serving as contact tracers. With the Lord Baltimore Hotel, so one of the things that we advocated for early on, initially, the Lord Baltimore Hotel was very focused on those who were homeless and maybe those who needed recovery and didn't have somewhere else to go. We advocated very strongly that this also needs to be a recovery hotel for our immigrant community living in crowded housing. The challenge, and we even signages in Spanish and everything. The challenge is that many of them are very uncomfortable going to the Lord Baltimore Hotel because they, as you can imagine, and rightfully so, have concerns around family separation. Ensured that with security that, ICE would not be able to access the Lord Baltimore Hotel and all of that. But even with all of the precautions, it's that trust piece that I sort of talked about in the earlier part of my presentation where there's a challenge. So one of the things that we've talked about with Build, and we're trying to sort of explore, foundations that have a lot of money, is can we actually pay people to quarantine at home safely when they can? Because for a lot of people, to quarantine also means that they're losing income. Because when they can't work, they actually can't earn income for their family. So that's been reluctance for people to come to the testing site, because they're like, well, if I'm found out to be positive, I'm going to lose 14 days of pay, or I may actually even lose my job. So, it's sort of like, how can you sort of help give that economic support to the family so they can safely quarantine? That is our biggest challenge is the immigrant families who've gone to the Lord Baltimore Hotel have found it to be a wonderful experience. And, we're trying to use our communications team to capture their stories to share with others, but, they're uncomfortable and I can understand why. So that's been a big challenge.
Are you able to, thank you for that explanation. Are you able to share any statistics on the percentage of folks who were traced, who responded, and the number of folks that Hopkins testing system has been able to identify, just to show the level of effort you guys are giving? Yeah,
so actually it's interesting. I asked Dr. Kathleen Page about this last week. So I think I have the hot off the presses numbers. Let me just, we tested well over 1,000 people at that site. So I know it's about 940 have been Latinx. And then let me give you the numbers for the non-Latinx, because we've opened it to everybody.
I know, because I was there.
Because you were there, right? Exactly. So
highly recommended.
Okay, so 937 Latinx individuals and 640 non-Latinx. So we've tested about 1,577 individuals, and that is as of last Thursday. I will get you the numbers on the percent that we've reached through contact tracing, but we've been able to reach the majority of them because we've been using these trusted approaches to the contact tracing. But if okay, Chairman, I will try to get that information while you.
That sounds fine, because we have
share
other questions. Yes, absolutely. Thank you. We have next Delegate Hill, Terry Hill.
Hi, thank you, Dr. Golden. Nice to see you again. I appreciate
Yes.
the presentation. I
Yes,
especially
thank you.
appreciate the historic background, which leads to sort of the first question. What has your data shown about the morbidity and mortality for our minority communities? I'm concerned that part of the problem we've seen with the higher mortality is that with that historic background, many Black and Latinx communities, when they're told, stay home, call us if it gets really bad,
Yeah.
have a different idea of what really bad is. And by the time they return to the hospital, much, much later than it would be for a population who is used to, you know, when I say it's bad, and I can expect care. So are you finding that folks are delaying in presenting in the minority populations more than in the majority populations? And how, if so, how are you dealing with it?
Yeah, so the answer is yes to that. And the delays, I think, are different in the Black community compared to the Latinx community. So in the Black community, people are recognizing that, okay, something is wrong and I'm not feeling right. And then they will go to the emergency room. Early on in the pandemic, they wouldn't even test people. They would say, well, you know, you probably just have a cold or something. And then they would go back home and then things would get worse. It wouldn't be till the second or third time they would return. Somebody would finally test them. Of someone that, a friend of my parents, where the person came back the third time, finally got tested, had COVID, was so sick he was immediately admitted to the hospital and died within a week.
Right.
But he is so that's one of the challenges is we have been really ensuring that when people first present, you know, in any of our clinical care settings, that they need to be tested for COVID and not questioned. And then so what we're finding in the Latinx community is that, again, because of the concerns I mentioned about the delay, about concerns about if I don't work, then I'm going to lose income, they're waiting until they are so sick that they're finally presenting and have to get admitted. But what's interesting is the mortality rate is higher in Blacks, but it's not actually higher in the Latinx community. I think there's two reasons for that. Number one, the Latinx community is getting infected is younger. So at least in our Johns Hopkins medicine data, it's a younger population that's getting infected. But I also think there is this impact in the African-American community. If you think about the structural and historical context I presented, that has been evolving over 401 years. And so what actually ends up happening over time is that with each generation, those kind of sort of discriminatory and other stressors that we've had to endure, they actually can change your risk for health disease. So like each subsequent generation, like the fetus has to survive sort of this stressful exposure. And so there are adaptations made in utero to do that. But then that fetus survives, becomes a baby, but then when they become an adult, that puts them at higher risk for disease. So I think because of the chronic enduring stress that the African Americans in this country have endured, it puts them at higher risk for chronic diseases. And then that's why there's this higher risk of mortality. You know, our immigrant community, our Latinx community haven't been here quite as long to have that experience. And my hope is that they will not have to have that experience and that we can begin to address the structural racism in this country that not just impacts Black communities, but all communities. So I think that that's some of the reason that we're seeing the differences, is differences in age, but then also differences in exposure to structural, long-term, long-standing structural racism, so.
Okay, and differences in like you said, once you're told to stay home, you may stay home longer because nobody's going to help you, right?
Yes, I would tell anyone who is in the minority community, if you do not feel, what I've been advocating is everyone knows their body. If you feel like you are sick, you need to go back and demand what it is that you need to have for testing.
Okay.
You know, I think that is really important, that we need to sort of instill in our constituents the agency that they need to have over their health care. And that's really important.
I appreciate that. And I guess my final question has to do with the fact that the criteria for testing has been fluid. You know, it's since the beginning. So it's really difficult to compare numbers or even positivity in September to what it would have been in June because
Yeah.
the year for testing was different. So how
Yes.
is that affecting the numbers and the data that you're seeing in terms of your ability to adjust and make the kinds of changes we need to deliver the kind of care that we want to make sure is delivered? So.
So yeah, that's another good question. So one of the things we've seen, of course, is in the spring, like around May, June, we had more testing available. So your numbers were going up. And so now they seem to have leveled off a bit, but those patterns that we see of the higher infection rates in the Black and Latinx community, and I also see in the Native American community, we don't have as many Native Americans in our state, but out West, this is a really big issue, that we're still seeing that those communities are disproportionately infected. And the African American community is still dying more despite, so even as criteria have evolved, those patterns still look very similar nationally.
Thank you very much. I don't see any other questions in the chat room, but I do have two actually. Are you seeing any trends related to behavioral health issues among patients, especially in light of COVID-19? Mental health, I know the crisis hotlines, they said the calls have gone up more than 95%. You can talk to us about that.
Yeah, so that the anxieties naturally are very high in the community, certainly around COVID, but then, in addition to the COVID, there's economic instability that, has resulted from the pandemic. So a lot of people are very concerned about job loss still and financial stability. And then while all of this has been going on in the summer, we've had what I've started calling like the second civil rights movement in our country, in a sense. And so I think there are definitely a lot of anxieties that are contributing. I have not seen data specifically trying to really quantify that yet in our state. But interestingly, and I think this is an interesting statistic, we actually surveyed the employees in our health system. So the healthcare providers, not just the healthcare providers, but all of them. And in our system, I think it's been about a 23% increase in reporting like rates of stress and anxiety just among, the employees. So I am certain that that's happening in the community as well. So that's going to be an important component of care.
Thank you. And thank you for working with me and Aaron and the committee on some of the bills that we're working on regarding data reporting, as well as racism as a public health issue. So I know that Prince George's County has the highest number of COVID-19 cases in the entire state out of the 24 jurisdiction. And then the SIPCO with the highest number of COVID-19 cases, over 2,800 and something, is 20783, which is the immigrant Latino community in Prince George's County. I was talking to yesterday, and some of the problems that I think we need to address with, legislation and reporting that we're working on is the fact that some of like the 20783 SIPCO, some of those of the people that live there go to DC or they'll go to Montgomery County. So hospitals are communicating with each other within a county, but they're not communicating across jurisdictional borders.
Yes.
Capture all that information so that we can get the clear picture of who these people are, how are they being affected as well. And I know that we need to change, some of the laws to allow for that. So
yes,
you work on that.
No, and it's been a pleasure to partner with you. I think it's really important to find sort of kindred spirits who, really have the ability to, to legislate some of the things that we need to do to support our communities.
Thank you so much for your testimony today. We're really grateful. I know you have another commitment.
Yeah, I'll stay on till 1:30 because I'm interested.
Thank you. So in our second panel, and thank you committee for your patience, we're going to hear from Dr. Nylish from the Anne Arundel County. He's the Anne Arundel County Health Officer. And I believe he's on.
Okay.
Wonderful. Great to see you. Another great partner. Welcome to the HGO committee. And I see that our wonderful Cher is on the call as well. She's been listening. Thank you so much for your support.
Thank you. Thank you for having me here today. Appreciate it. It's I was really happy to hear your lead off to the segment, Dr. Gelden. Sort of makes my job a little easier. I don't have to review some of these slides as much. I'm just going to echo what she said on a lot of the drivers around disparities and how we got here. Next slide, please. So when we talk about health equity, we're talking about making sure that everyone has a fair and just opportunity to be as healthy as possible. We are noting in our county is really no different than what was being noted elsewhere, but we do know that data matters, and our data show that racial and ethnic disparities were persistent across a variety of health measures. And that report first came out, the one that I'm referring to last summer. And actually in November of 2019, Anne Arundel County declared racism as a public health issue, and we were the third such county to do that in the country. And we committed to standing up an Office of Health Equity and Racial Justice to be able to address that. And we specifically pulled out the racial justice piece because that is, while it is certainly a part of health equity, it has been going on for centuries in terms of disparities in the Black community, in terms of not just health outcomes, but health access to care and the other social determinants of health. And so we wanted to draw that out and highlight that. But of course, as with almost everything that we talk about, COVID arrived. Next slide, please. And we had to change our timelines. And I think it was probably within weeks, we started noticing that those same disparities started showing up in our COVID data, right? And I think that it's really important to remember that the virus doesn't really care who it's infecting. It doesn't have any racism or sexism or anything other ism, right? What we saw was that the virus was tracking along existing disparities and inequities in our society. And so we pretty much fast-tracked our health equity and racial justice work, and we said, we have to do it in the context of COVID. This is an issue that is blowing up as we speak, and so we launched in early April. Next slide, please. Our COVID Health Equity Initiative, and we wanted to make sure that we were identifying why we were doing that. And so we note that our health is inextricably linked to those around us, neighbors, family members, child and adult care providers, school teachers, delivery service people, grocery store clerks, friends, families, workplace colleagues. We are not an island. It is, and we hear this during COVID, this is what I want to do for me, but in a public health pandemic, your actions affect others, and we are interconnected. We also saw that inequitable systems were manifesting themselves during COVID, just as they do during other things. And so our healthcare, access to healthcare, public health investment in infrastructure, and disinvestment, frankly, in public health over the years, and economic systems really put us in a place where certain groups were more susceptible. Dr. Golden touched on some of the issues around access to care and trust in care in different communities. Certainly that colored the approach to how, not only how people engage with the healthcare system, but how the healthcare system engaged with people. And in terms of public health, we know that we've been underfunded for a long time, and we've seen that, particularly from the economic crisis of 2008-9, our funding dropped and it's never recovered. And so our ability to move fast, while we went as hard as we could, without a federal government support, it's been challenging. And then disproportionate suffering during the COVID pandemic. We see that low-income workers, people of color, people in neighborhoods that are economically depressed, they're the ones being hardest hit. And so, next slide, please. And so the guiding principles of our health equity work are to collect, analyze, and report disaggregated data. And that disaggregated word is going to do a lot of heavy lifting, because if you don't try to understand why the data looks the way it does and what are the different facets that make it up, you're going to miss some of the threads that are in there. And it's really important to remember that if we talk about how many cases there are, If there's no disparities, then we would expect the same proportion in every racial and ethnic category. And if that's what we found, that would be fine. And we could move on to see where other inequities are. Obviously, that's not what we found. We want to make sure that we include those who are most affected in decisions, and we're going to talk about how we did that. We want to establish and empower our teams dedicated to racial equity. And then that means making sure that we consciously consider that as part of our work in figuring out how we're going to respond to COVID. Working to fill policy gaps while advocating for more federal support. And there are a few policy gaps that I think we can address, chief amongst them being job and income guarantees for people who either are diagnosed with or suspected of having COVID. That certainly more directly affects those who are lower wage, those who are undocumented, who cannot take time off from work, either for cost or job security reasons. And so that just, in addition to their own health, perpetuates that spread of the virus and is also a public health problem. And then in the longer term, investing in public health, healthcare, and social infrastructure, particularly. Next slide, please. And so the health equity framework really starts with making health equity a strategic priority, explicitly declaring that it is, and then developing the structures and practices to support that work. Taking specific actions, and then on the longer term, decreasing forms of discrimination within an organization and developing partnerships with others. Next slide. So the first thing we did, as I mentioned in April, early April, is we launched our COVID-19 Health Equity Initiative. And we did that by bringing together community members and leaders, initially weekly, because there was just a lot to discuss, and now monthly, to both hear what they were identifying as challenges, but also to work in partnership to address those challenges. I think sort of the animating phrase is "nothing about me without me," and that's really how we approach this work. Next slide, please. So I told you that we relied on disaggregated data. And so I wanted to share some of that disaggregated data with you. And it never tells a really clean story, right? We are trying to understand not just what's happened since the beginning of COVID, but also what's happening today. Because ideally, we are taking steps and actions in response to the data and in response to the stories from the community, and then we're making positive change that's going to address that. It's a bit of a busy slide, but the light blue is the percent of cases overall by race and ethnicity. The dark blue is what's happened in the past 4 weeks. And we want to pull that out because we want to see what are the trends doing. The light red is the percentage of deaths in that race and ethnicity grouping. And the dark red is percent of deaths in the last 4 weeks. And then lastly, of course, the green is the population. So sort of your baseline, or what would you would expect if there's no disparities. And what we see in Blacks is that pretty steady overrepresentation of cases by about 1.5 times what you would expect in the population. We also see that in the deaths over time. And that's been persistent. When we see in the past 4 weeks, the percentage of deaths, that number is obviously looks a lot higher. It's a bit skewed because we have had actually very few deaths in the past 4 weeks. And so your percentages get thrown off. But I think the larger message here is that those cases and deaths have been overrepresented. We see a different story. And it's really just interesting to hear the parallels with what Dr. Golden was talking about. We see in the Hispanic community, we see about a 3 to 4 times overrepresentation of cases compared to population. That's come down a lot, and that's actually been due to significant targeting of testing, educational resources, and bilingual contact tracing, specifically targeted to the Hispanic community. And we see in the past 4 weeks that the percentage of cases is down to 10%, which is really close to the population. And I think suggests that we've made some good traction there. But we've seen that deaths overall haven't been overrepresented in that population. Once again, largely we think largely due to the age issue, the average age of those who are positive in the Hispanic population is a lot lower than the average age in the population in general. We see that in our Asian community, we haven't seen the disparities rise. And so while we certainly have targeted outreach, we haven't devoted as many resources because, as I noted, we haven't seen a disproportionate impact yet. And hopefully we don't. And then the other category is really those situations where we either Native American or where we don't have a classification because it hasn't been recorded yet. Next slide, please. And so one of the things that we specifically tracked was percent positivity. And so as a reminder, although I'm finding that everybody seems to know public health statistics and epidemiology at this point, which is really kind of cool, actually. But percent positivity is the percentage of positive tests over the total number of tests that were done. So early on, we really made an effort to understand the percent positivity by race and ethnicity as a way to understand where we needed to be doing more targeted testing in order to identify more people in communities if there's a higher percent positivity rate. So this is going back to July 9th. The left side of this shows what our percent positivity was by race and ethnicity. So this was about 2 months ago. And we see that except for Hispanics, the Asian, Black, and white populations were under our 5% positivity rate. There's still a disparity between Black and white, but it's fairly small. I will tell you that if we go back further, we saw a higher percent positivity for Blacks. But for Hispanics, we see 14.1% positivity, which is just massive. And so we spent a lot of effort targeting education, testing resources, including community testing, and we've been doing community testing since late April. And by the last data collection period, August 20th to September 3rd, we've gotten about 9 percentage points off of that. And so we see the percent positivity for Hispanics down to 5.4%. Still not at our goal, but much better and trending towards where we needed to get. But we've also seen some slight increase in the Black population as well. And so this is what I mean by it's a complex story. We're always tracking it. We're always trying to adjust. And there's no such thing as victory, right? We're always going to be working and staying on top of this. And we see in public health, something's going to happen, and you need to both be ready for what's possible, but also ready to react for those things that you just couldn't anticipate. Next slide, please. And so Dr. Golden went over with why some of the reasons are that it's kind of cool to have you lead in. I just referred to you, Dr. Golden, but why we are seeing some of these trends, right? We see in minority populations more likely to be essential workers, frontline workers, less likely to have health insurance, either health insurance at all or comprehensive health insurance, issues around access to housing, food, basic necessities, and then the trust issue with the health care system and potentially the public health system too. One of the things that we heard a lot was that from the Hispanic community was concern about interacting with the government. We understand that we're the county's local health department, and we don't have any authority, much less interest in doing anything related to immigration status or anything like that. But for communities that are scared of that, that doesn't really matter, right? Where does our data go? How do they know? How do they know we don't mean anything? So there's a lot of those issues that go beyond simply what happens in the healthcare system or the public health system. Next slide, please. So from our COVID-19 health equity initiative, we identified a number of barriers, and these barriers were identified by community members. Communication barriers, wanted to make sure that people were able to have access to accurate, updated information, but particularly that it was easy to understand. Knowledge of testing procedures, youth awareness, Access was a key issue, transportation to testing locations, distance to testing locations, basic needs, food, housing, income, those three big ones were mentioned over and over again. And then the community, the lack of trust and stigma related to COVID-19. And also concerns about ability to engage in the community and share this messaging and share safety in light of social distancing requirements and regulations. Next slide, please. So out of that came a set of proposed solutions. Chief amongst them was to actually publish the data that I just shared with you about race and ethnicity data for cases and deaths in the county, and then the percent positivity as well. Ensuring that we had access to care. And so what we did in late April, so we met in early to mid-April, and a few weeks later, we stood up our first community pop-up testing site. And the way those work is that we partner with different community institutions, libraries, churches, grocery stores, Elks Lodges, whoever wants to partner with us to bring our testing to a community spot, to do it as walk up. All of our testing from day one has been free. We charge insurance if you have insurance. If you don't, we cover the cost. And we've been doing that weekly, typically 2 sites per Monday until this week, when we actually were able to go to 5 days a week. So we're really excited about that opportunity to be able to increase our community testing. Addressing language barriers. So we have somebody speaking Spanish on our COVID-19 health line, and making sure that we have utilizing best practices via social media and convening stakeholders to address the communication issues. Next slide, please. So you can go to the next one. Additionally, we set up a Spanish social media page. It's our Salud Equidad, which has really been taking off. It took a while to get set up. We always have a lot of ideas, and sometimes the execution takes longer than we want, but it is up now. I mentioned the testing sites, and we've also hired 11 new bilingual contact tracers, 7 during weekdays and 4 on weekends. And that was actually a huge push of ours. And one of the reasons we were able to get so many was because we depended on the folks in our health equity initiative to spread the word and encourage people to apply. What we find so often is we put out our job notices, and the people who look at our job notices are interested in public health. And so we only get a certain selection of people, and we wanted to really widen our net. And we've also made sure that we have bilingual staff at our testing sites. Next slide, please. And we also partnered with other county agencies. The county executive launched the Excluded Workers Program, which provides financial support to people who are not eligible for other programs. So essentially provides, to a large degree, financial support to undocumented individuals. I mentioned that we're standing up our Office of Health Equity and Racial Justice, but we've also been awarded through MDH actually a program to provide rent utility and assistance, and we're really excited about that. Health education videos created specifically for the Hispanic community and coming up for the African American community. We actually have a $60,000 media program to reach those communities over the course of the remainder of the year. And then opening up testing to residents outside of Anne Arundel County, making sure that people who work here but don't live here can get tested here as well. It means that we need to stretch our dollar further, but it's really important for what we're doing to be able to do that. You can go ahead about 3 slides in the interest of time. My ask is all of you to like our Facebook page. That's how we're gonna get the word out. I like to give homework in every talk I give. This was the MDH program that I was mentioning, and Dr. Braithwaite will, I'm sure, speak about this. It's a $200,000 award, and we're using the bulk of the money to help pay back rent and utilities so that we can keep people housed. That's a critical need right now. And as much as there is an eviction moratorium, that doesn't mean the rent isn't due. And that doesn't mean that there aren't people who are still getting evicted anyway. And we've heard that over and over again. And so keeping people housed has been one of our goals. We actually dedicated to that right at the beginning, to housing those who are unsheltered and to preventing homelessness in partnership with social services. And then we'll also be giving out care packages that have medical and hygiene supplies to be targeted to the zip codes most impacted by COVID. Next slide. Actually, you can go one more slide, please. We talked about the testing already, and I just wanted to give you a sense of what our testing looked like. On the left side is our fixed site testing, and on the right side is where we're going each day in the community to do testing. And we're pretty much getting around the entire county. And it's this commitment to actually meeting the community where they are that's critical in addressing the health equity needs of our county. If you can go ahead 2 slides, please. And I would encourage any of you who are interested, and I know some of you have already been there, and I thank you, to join our health equity calls, both for your perspective and for your knowledge of what's going on in the community. I found those calls to be some of the most enlightening that we have. So with that, I wanted to thank you, and I'm happy to take any questions.
Thank you for your time and for this wonderful presentation. We do have a question, and that is Delegate Lewis. You're muted, Delegate Lewis.
Oh. Thank you, Madam Chair. Thank you, Dr. Nylash. We miss you in Baltimore. My question for you is, what is your total testing coverage rate? You described the disparity between different racial and ethnic groups, and I'm wondering how the expansion in testing is affecting the positivity rates. In Baltimore, we've hit 11 or 12% total population testing coverage. Where are you guys?
I think we've hit something like 20% of the total population tested. We set for ourselves a target of testing 2% of the population each week, and we hit that mark, I think, about 8 weeks ago now. But we're also looking at how we make sure that once again is equitably done across racial and ethnic lines, that 2% of each population. We haven't quite, to be quite honest, we haven't quite figured out how to measure that properly, because we don't get race and ethnicity data for everybody who's being tested, much more reliably for people who are positive. So we still have some data gaps there, but that's what we're targeting.
That's helpful. Thank you so much.
Are there any other questions? I'm looking at the chat here. I don't see any. I actually have a question for you, if I may. I know that the health officers are meeting every 2 weeks, correct?
We meet monthly as health officers.
Yes, and so you meet monthly and you have been sharing the information regarding what's going on in your particular jurisdictions, right?
Mm-hmm. Yeah.
Are there any questions? I mean, is that data being captured is my first question somewhere, right? And are you communicating with the hospital systems as well? And is that data being captured? Because that's the only way we're going to get that entire picture.
So we work closely with Anne Arundel Medical Center and BWMC. We meet with them once again now monthly. We were meeting with them weekly prior, and working with them on how they're addressing health equity in their systems. Each of them have some different approaches, but data collection has been a key part of that. And in fact, we are partnering with each of those systems to deliver testing, and then hopefully flu shots as well, to to African American and Hispanic majority communities precisely to be able to address those needs. In terms of data sharing amongst health departments, a lot of that actually happens at the state level, because the state is, for many counties, particularly the smaller ones, is driving that data stream. The larger counties, such as Anne Arundel County, we certainly have the ability to do more on top of that. So we don't necessarily aggregate data amongst the counties because that's being done at the state level.
So if you had a magic wand, right?
Mm-hmm.
Is there anything that you would like to see from the Office of Minority Health and Health Disparities or the Department of Health, learning from what we're going through, right? Moving us forward. What would those improvements be?
I think that for whether it's for MDH or for us generally, I mean, I think that the key is to build in health equity from the beginning, and not to do it separately or secondarily. I think that that's probably, there's sort of a general adage that it takes you get about 80% of your effort for about 20% of the people in a healthcare setting. I think the same is generally true in the in the public health setting as well. You need to devote about 80% of your resources for the 20% of the population that is harder to reach or experiencing health disparities. And so I think building in health equity from the drop is really the key to being able to address them effectively.
And is your group, the health officers, all 24 of you, are you coming up with some recommendations?
We have been talking about working on identifying a health equity committee amongst the health officers. I'm a part of that conversation. Just to be honest about it, are just having trouble getting launched on that because of the COVID time requirements. But that is our intention.
And I want to thank you for, I know your office is working with my intern on the bill that we requested declaring racism as a public health crisis, and you have been extremely generous with your time. Are there any other questions from the committee? I don't see any in the chat room, and I want to thank you so much for your time and all your efforts. Next.
Thank you.
It's our pleasure to have you. Next, we have Dr. Jinlin Chen, who's the Acting Deputy Secretary of Public Health Services at the Maryland Department of Health, and she will be with Dr. Nell Braithwaite, who's the Director of the Office of Minority Health and Health Disparities. Welcome to the Health and Government Operations Committee.
Hello, and thank you, Madam Chair.
Our pleasure.
I am also joined by my colleague, Dr. Noel Braithwaite, and I believe he is also on the line.
Yes, I'm here.
Great. Hi, Dr. Braithwaite. So thank you, Madam Chair, Chairwoman Pendergrass, and members of the subcommittee. And I also wanted to thank the members of the panel, Dr. Golden, Dr. Kalyanaraman, for their really important remarks and really setting that local context, which, I come from the local, and so I absolutely recognize how critical that is to make sure that that local context and those connections at that level are strong and firm, and our role with the Department of Health now, as it always has been, is not only to make sure we continue to focus on those needs, but also to support our local health departments and our community-based organizations and others across the state. As we talk about health equity, I think it's an important conversation to have in any setting that we discuss related to health, because there's certainly a lot of factors, as has already been reviewed, that impact the outcomes that we see and the numbers that we see. And so this continues to be an important emphasis and focus for the Maryland Department of Health as we work on our COVID response and ongoing plans into the fall. And in fact, the governor today just issued a proclamation recognizing Hispanic Heritage Month and the important contribution of the Latinx population on the richness of Maryland communities, and so that continues to be important, and I would say that that's important because it folds into the work that we continue to do. So I will run through our presentation with Dr. Brathwaite, and certainly happy to answer questions at the end. So just very quickly as an overview, we start out by just setting the stage in terms of the roadmap to recovery. Some of the key tenets that we established early on in our response to the COVID pandemic, including testing and contact tracing and PPE. We continue to do a lot of testing around the state. We've now cumulative conducted 2.2 million tests, PCR tests, and molecular-based tests around the state. And early on, my role had been to really focus on expansion of community-based testing and support of tests, especially at the local health level, and to provide tests to local communities. With contact tracing, we've now had over 33,000 cases since our efforts really ramped up over the early part of the summer, with over 41,000 contacts reached and interviewed by contact tracers, both through our contracted entity as well as with local health departments. PPE and other medical equipment is really critical and continues to be a really important part of our overall response. And so we've distributed 78 million pieces of personal protective equipment to healthcare providers, to primary care providers, and as we speak, we are providing supplies for schools and also working with the State Board of Elections on their needs in the coming months. With the election. And then with the hospital surge capacity, we have been fortunate in that we have not had to fully use that capacity, but early on, certainly as you were well aware, this was an important resource that we absolutely needed to put in place. And so we have still approximately 6,700 surge beds, and we continue to make those available, and we are maintaining them as we go into the fall. Next slide. So I won't read through every single bullet point here, but a lot of what we've done is identifying partners, is making sure that the policies that we have in place provide access to individuals who need testing, whether for Medicaid or in partnership with local health departments and other entities to establish these testing sites. Some we have actually done, stood up using the state's resources, for example, at the Baltimore Convention Center, which is done in partnership with University of Maryland and Hopkins, next to the Baltimore Convention Center Field Hospital, as well as at Six Flags in Prince George's County. And so those two sites were not selected randomly. Those are certainly large populations where we have seen a high number of cases and the impacts in those communities. We also have some data on the website, and this is something that, as I have stepped into this role in the last month or so, have been digging into the complexities of the data, as Dr. Kalyana has referenced, and making sure that we refine and expand the availability of that data to all of us as we make decisions, and again, as we continue on into the next phase of our response to the pandemic. We've talked already about some of the financial support, as well as logistical and even test supply support to local health for their community-based testing. And really early on, I think it was important that we emphasize that the testing supplies was, that there needed to be some thought in terms of how those testing supplies and testing resources were deployed to be able to reach hard-to-reach populations, minority communities, and other high-need areas within each jurisdiction. And so that was really important. In addition, of course, we've supported, as you have heard, VEEP sites, as well as other pop-up sites, working again very closely. Local health departments and local health officers are very much our partner, and we work closely with them nearly daily on a number of different initiatives around the state. So I will, next slide, please. So this just illustrates, this comes from our website. People can go there, and it's an interactive map that where people can find a testing site that's closest to them. The ones in green are cost-free, so that's, of course, very critical. And then you can see some of the other color codes there as well. There's other ways to stratify the testing sites that might be important for the individual who's seeking testing. So I wanted to make that available and to highlight that for you and for the public as well, that it continues to be important to get tested if they think that they may have been exposed to someone with COVID, or if they have symptoms. It is important to get tested. So next slide. This slide just shows where a number of our VEEP sites and other state-supported testing sites have been since the beginning, and so in the currently active ones, including, you can see that the Pimlico Race Course, where we worked with Baltimore City, over in Ocean City over the summer, and others around the state as well. Next slide. So I wanted to talk a little bit. So this data is on our website, and you can see certainly that that when you look at total number of cases by race and ethnicity, that the greatest number of individuals who've been identified with COVID-19 disease is among the non-Hispanic African Americans, followed by people who are white, non-Hispanic, and then the Hispanic population. Of note, there is still a fair amount of data that's not available, and because we get data from multiple sources, and one of the key sources, of course, is from the lab results themselves, and early on, and I think still to a great extent, there is inconsistency on the reporting of that information, either at the time of testing, or through the labs themselves. And so that continues to improve, I believe, but it is still a very large number, as you can see, where the data on race and ethnicity may not be available to us. So. And then deaths by race and ethnicity. I think that this has been talked about before in a previous presentation. When you look at the overall number of deaths, to date, today our total number of deaths is 3,706. And so when you look at this particular slide, you can see that the impact on all of us, really, but focusing in on the individuals who are non-Hispanic, African American, is quite high relative to the population, which you will see on the next slide, which is the next slide. Oh, there we go, the case rates, where this is by population size. And so we take the absolute numbers, and I think it's always important to show the absolute numbers, because when people need to know and understand that each one of these people are, have a family behind them and have friends who have cared for them, and certainly the number of deaths in our community is no small number, and we understand that impact. So understanding the impact there on basic numbers. But when you look at the case rates, you see then a difference there. So among, and this has been noted in the prior presentations as well, that when you look among the Hispanic population, their case rates, so these are the number of positive cases by their total population per 100,000, is 4 times as high as among the white non-Hispanic. And when you look at the African American, it's 2 times as high. Now, I will say that, in here, you see an other and non-Hispanic, and I will, in talking or hearing Dr. Golden, recognizing the importance of really understanding that group a little bit better. That encompasses likely the Pacific Islanders, the Native Americans, and others, but to the extent that we have that information in a way that we can pull that other category apart, I will certainly do that. But that's certainly a very high number, and just want to highlight that as well. When we look at the death rate, so on the other side of the slide here, again, the impact of the COVID-19 is much higher among African American, non-Hispanic African Americans compared to whites or Asians. And in fact, it's 61% higher, the death rate, compared to whites. And then among Hispanics, it is about 29, 30% higher. And that's cumulative to date. So as we know, there is a lot of the disparities that we see in other health metrics around the state are also reflected here, and some of it, as Dr. Golden mentioned, can be contributed because of some of the underlying medical conditions, and importantly, perhaps the lack of trust in the healthcare system or lack of access in many other ways. And so those are important metrics to keep an eye on. So, and there is ongoing work because our data continues to be, as you can see by the previous slide, the data not available. I think that's trying to make sure that we have good data and clean data as we look at this information around the state, and to really parse it down and to understand it better as we move forward. It is ongoing work that we are committed to doing. And I'm going to turn it over next slide to Dr. Brathwaite to talk a little bit about the minority health initiatives that we've undertaken so far.
Thank you, Dr. Chan. We recognize that all initiatives are driven by the data, and so you've got a good look at the data that informs our initiatives. And we started when there was a call for a response on the Eastern Shore in April to May, and this was associated with an outbreak on the poultry industry on the Eastern Shore. And so in addition to the mass testing, we provided some real care packages to the Haitian Creole and Spanish language communities. And this was done through the Office Minority Health Motor Grantees. And they were able to mobilize not only fellow grantees within the Eastern Shore, but also members of the faith and other communities of interest. So we were able to respond to the Eastern Shore breakout. In addition to that, we have been partnering with the 5 major local health departments that have the most cases and deaths. And these include Anne Arundel County, Baltimore City, Baltimore County, Montgomery County, and also Prince George's counties. And we have been able to provide them with funding through the CARES Act, and over $1 million for those 5 county health departments. And they were able to address some of the socioeconomic needs of their constituencies, and also communicate different messages that would enable them to know more about testing, help to break down the mistrust and distrust among community and some of the healthcare systems. And the continuation of our efforts will be ongoing. Next slide, please. And this slide will tell us what we continue to do. And this slide focuses on the messaging of different language media, and also the different kinds of modalities that we're using. For example, we have messages on WMAR, also the English Spanish PSAs and Bounce TV on testing, and other PSAs that are intended to reach minority populations. One of the interesting things and innovative things that we have done, in addition to what Hopkins has done with the same modality, is that we are going to utilize a mobile public health education unit to provide COVID-19 education. And this is going to be targeting code 21224 as a matter of urgent interest. We continue to support, in addition to the local health departments, we recognize the importance of the HBCUs. And so we funded 4 HBCUs, and they were going to undertake some studies through surveys in terms of knowledge, attitude, and practices of minority population during the COVID. And some of the interesting outreach would be in Baltimore City and also Baltimore County, and as far as Prince George's County. And then on the Eastern Shore, UMass, University of Maryland Eastern Shore, they'll be looking at some of the mental health issues such as depression and anxiety among the nursing home population. One of the other things that we want to do is to continue in our messaging, because we realize that messaging is a critically important means of not only enhancing testing, but also knowing more about what are some of the barriers to behaviors among our minority populations. These are some of the activities that we engage in. These are some of our initiatives, and we'll continue to respond to the needs of our minority population within the state. I'll hand it back over to Dr. Chair.
Great. Next slide. So one of the things that we've been pushing out, and you may have seen some of this, is the Masks on Maryland campaign, or the MOM campaign. And this is really the first phase of 3 phases that we're really pushing out important communication and prevention messages to enforce the fact that even as we work with all of our communities and reopening of schools and businesses and such, that it is really still very, very critical that prevention measures such as wearing masks be practiced, and to focus on the benefits of wearing masks rather than the mandate, and really how wearing of masks and other protective measures protects not only the person, but their family and the community, and all the things that we want and that we enjoy that have been certainly more difficult early on in the pandemic, and that we continue to work on now. We have produced 2 toolkits, one specifically for the Hispanic or Latinx population and audiences, and we've shared that with other state agencies, local health departments, and those are available on our website so that they can print those off and use them in businesses, for example. Next slide. In addition, we have had related events, and so these started out about in July, August timeframe, where we distributed masks, little packages of 3 or 4 masks at our testing sites. Initially, we started out with the Baltimore Convention Center testing site in partnership with the Baltimore City NAACP chapter to get the message out, encourage people to come and get tested, and also to provide them masks and tools essentially for them to practice good prevention when they left the testing site. We have since then hosted other events, again partnering with local community-based organizations, including in Harford County, in Prince George's County, and in Ocean City as well. And so we're now working on a plan to do something similar, but to expand it so that other communities can host perhaps their own events. whether it's related to testing or not, so that, again, reinforcing that important message that Masks on Maryland is how we're going to continue to recover. So that's something that we're certainly pushing forward on. So this is just an example of some of the visuals that we pushed out. Next slide. Another important component, and Dr. Golden really, I think, provided a lot of detail about this, as we have looked at the impact of the COVID-19 disease on different populations, different communities, it's not just about numbers. It's important to listen to our partners. And, we early on heard from Hopkins and from the Archbishop and others that they were seeing some concerns in the communities that they were working in. And so it is our role and goal to support those efforts at the local level. And so we did pull together an interagency task force with partners not only from the state, but importantly from Baltimore City, with the health department, with Hopkins, with faith-based and other community organizations to understand what's happening in that 21224 zip code. And I think that really from our perspective at the state level, it's really diving in, not just into that community, but then beginning to take the process and the lessons learned and working to expand that certainly across the state and working to engage many other partners to understand what the impact has been, and knowing that our local health department partners, such as Dr. Kalyana Raman and his colleagues, his fellow health officers around the state, really have always had a very, focus on the community level impact and understanding of that. So as we engage health officers, community-based organizations, and others, the work that we're doing with this Hispanic Outreach Task Force is really critical to that. The focus has been on providing from the state's perspective, what operational support and technical assistance that we can. Again, so much work has been done in terms of the testing and the outreach, the way that, if we can support contact tracing, working with the city health department. We've provided the grant, some funding for the non-congregate housing and isolation strategies. One of the things that's come out of the discussion that is exploring an intervention pilot program. I think that Dr. Golden may have mentioned this as well in her comments in terms of understanding better what some of the challenges are. And we can well imagine that being told to home isolate after a positive diagnosis can be really devastating for an individual and also for that household. Because that person might be the sole breadwinner, they may not be able to easily isolate in their house if there's other people who live there. And so we want to understand whether, how we might be able to support up to 10 families in the initial pilot to support the isolation, the care, cash assistance, food delivery, and other wraparound. And depending on how that pilot goes and the results that we see from it and lessons learned, we certainly would look to expand it, if possible, to other communities in the fall. So, next slide. And I would say that this is sample Hispanic outreach material. About a month or more ago, we pulled together a group of community organizations and influencers from around the state to really provide some advisory feedback on ways we need to better communicate and improve our outreach to minority and other underserved communities. And, some of that feedback is reflected in some of the materials that I've shared here today, but we did engage as well some individuals from some of these community-based organizations to help with our messaging, so community influencers and such. And so I don't know if it's possible, and I'll ask the individual, the IT person, I think his name's Dylan, if it's possible to play that very short clip. So for those who understand Spanish. I'm not sure if the sound is on, but Oh. I'm not sure if the sound is able to be played, but okay. So the purpose of this of Doctora LaRue is because we really wanted to focus on contact tracing and the importance of people participating in contact tracing, because you know, we have heard, you know, that trust issues are certainly a major concern, and contact tracing for public health is part of what we do on a day-to-day basis, but certainly not on this scale and not to the number of individuals that we are having to reach. And so this may be for many people the first time that they've been in contact with a contact tracer. And so we want to be sure to educate all people about the importance of contact tracing and how it helps us as a state and community to prevent the ongoing transmission. So I apologize that it wasn't able to be played, but we can certainly provide that link later. Next slide. Great. So I'll close here, and again, happy to entertain questions with Dr. Brathwaite. Our priorities for the fall, certainly, as I mentioned, expanding the Masks on Maryland campaign and our flu vaccination campaign, which is now in the works. Flu vaccine, I will emphasize, is going to be more important now this year than ever, and so we're very focused on that. COVID vaccine, I would also be remiss if I did not mention the importance of COVID vaccine, and so as we have pulled together some of our groups with stakeholders in the community, we'll certainly be looking for ways and opportunities to engage, to have conversations about COVID vaccine as we move forward in our planning. The continued partnerships with our important local jurisdictions and local health officers on minority outreach and other underserved populations. And then very importantly, and I have heard this, you know, certainly loud and clear, that as I am digging into our data, it is really critically important to refine our analytics and to improve our publicly available race and ethnicity data for you know, our entire population and for decision makers to understand the impact in smaller communities and racial ethnic groups. And then, of course, our contact tracing work and analysis continues. We are, and I didn't mention this earlier, we're doing also another pilot in Baltimore County that would connect some of the contacts of cases with some testing efforts so that we might be able to have a more targeted intervention. So we're working with the Baltimore County Health Department on that right now and rolling that out. And so that, again, is part of our overall efforts to expand testing and to expand the work of contact tracing and particularly trying to make sure that individuals who are identified as cases then have, you know, their contacts and others be able to be connected to care. So I will stop there, and I'm happy to hear comments and any questions.
Thank you so much, Doctor. We really appreciate your time and your efforts. We have a question, the first one from Delegate Collison, followed by Delegate Hill.
Thank you very much, Madam Chair, and thank you, Dr. Chen, for this great information. I want to make sure that I understood what was being presented in slide 7. And I don't know, Dylan, if it's possible to bring that up, but what I saw on one side was the number of cases, so slide 7, the number of cases per group, and then on the other side, the death rates. So I just wanted to understand that if there are 4,000 Hispanic positive cases out of 100,000 in the population, are you now saying, with the other side, are you saying that 66.8% of that 4,000 have died? Or am I reading that wrong?
No, thank you so much, Delegate, for that question. So, so if you are on slide 7, that is about case rates. And so case rates, as you noted, is the per population size. And so to take your example, so if you looked at slide 6, the total number of cases, so people identified who were Hispanic or who are Hispanic with COVID-19 cumulative is nearly 26,000.
Mhm.
So then you divide by the total population of people, the estimated population really in the state of people who are Hispanic, and multiply that by 100,000. So meaning for every 100,000 Hispanic people, there are 4,000 cases so far. And then when you go to the deaths, it is similar in that if you look at the number of deaths among the Hispanics population, there's 430 deaths known to date. And you divide that by the total population, which gives you 66.8 deaths per 100,000 population.
Okay, so it's back to the 100,000. Okay, I mean, it's still bad. I'm not saying that, but you know, when I first saw it, I was really struck by, you know, what I thought was a horrific figure. Still extremely bad, but all right. Thank you very much, Doctor, for clarifying that for me.
Absolutely.
Thank you. Next, we have Delegate Hill, followed by Delegate Bagnall.
Thank you, Madam Chair, and thank you,
Pleasure.
Chan and Dr. Braithwaite. A couple of things. So the public health department has been sort of chronically underfunded. I mean, going well back before your term began. And it's also been under-resourced. So the pandemic has, you know, put it at the forefront of all of our concern, and you've initiated a great number of programs specifically to deal with minority health disparities, but also to deal with the public health outreach generally. Can you tell us what or which of these kinds of efforts do you see promoting going forward so that we can start to close some of these disparities so that we can have a better public health foundation statewide, if you understand my question?
Right, and so it's always hard to say, you know, early on, certainly in our response and, you know, every state's response, as we received dollars from the federal government as part of supporting state-level response efforts, there was a lot that we had to, you know, stand up very quickly. So we talked about at the beginning with hospital surge and testing and contact tracing, PPE, and a lot of things that were really critical for everyone. In terms of the communication piece, I think that the work that we're doing to do outreach within community, within minority communities, working with community-based organizations, you know, I think that targeted and more focused communication efforts within our larger communication plan is really critical. Making sure that we stay engaged with our community influencers, community organizations, community leaders, and understand that, you know, data is an important element of the work we do that I'm very committed to, but making sure that those connections and that conversation continues. And, you know, that is something that working with Dr. Braithwaite, and he may, you know, that is an important element of making sure that our messages carry forward. I don't know if that entirely answers your question, but that would be my initial thoughts.
Okay, no, that's good. I mean, so it sounds like you're saying you see a need beyond COVID for better partnering and outreach in the community, and that of course requires better funding and resourcing for public health. And I hope that your superiors at MDH and the administration hear that loud and clear. So we have a pending cut in Medicaid reimbursement rates coming up. So how do we continue to do what needs to be done as we enter maybe the 4th inning of the 9-inning pandemic if Medicaid rates are going to be cut for providers?
So I think that as with many budget questions, I think that looking at the very big picture as we go into the next fiscal year's budget season, we are facing tremendous budget shortfalls across the board. And so looking at how we can continue to support our healthcare providers who are at the front line and working in all communities, not only to manage COVID-19 pandemic, but all of the other things that are also, the things that we all are aware of, so diabetes and heart disease, blood pressure, and childhood vaccinations and others. And so we recognize how important all of those efforts continue to be. But it must be balanced with, and this is the bigger picture that I think that all of us are facing right now in terms of how we balance those with all of the other important work that is being done within the health department, but I would say also with other state agencies as well. And so I think that those budget discussions are to come for sure, and we are in close contact with our colleagues at the Department of Budget and Management, and understanding the concerns and questions that are coming from you and from others.
Okay, Madam Chair, if I may, one last question.
Sure.
Thank you. So I appreciated your talking about deeper dive into data analytics, and I think that's critical. I just want to know if among the things that you're committing to is looking at our zip codes that have had the highest cases or incidents of COVID, and disaggregating to see how much or how many of those cases were due to outbreaks in congregate living facilities. As I understand in some parts of Baltimore, that it wasn't the neighborhood that had the high rates, it was the nursing home in the neighborhood. So will you be breaking that down a little bit better for us going forward in all the zip codes?
That is an excellent question, Delegate Hill. And so to the extent that we are able to, I think that it's because when the data comes to us, most of the information actually comes to us from the laboratory itself. And so to the extent that we're able to identify where the test actually originated, so where the person was at the time of testing, we're not always able to know whether they were at one of our community-based testing sites versus a skilled nursing facility. And as you know, in the spring and even now, there's a tremendous amount of testing happening at our nursing homes and assisted living settings, and so and other settings like that are congregate living types of facilities. So I think that to the extent that our data allows us to hone that down in a way that is reliable, we certainly want to look at that information. And, there's a lot of very smart people around the health department and certainly around the state as well. And but there are certainly data challenges when we talk about, well, where did this test originate and who is this person, down to that person level.
Well, I would just say that in the beginning, when we asked for the minority data, we were also told it wasn't being gathered, and the answer was to ask for it. And so to a certain extent, if you ask the testing site to begin to identify, might that not help? Okay, thank you, Madam Chair.
My pleasure. Thank you, Dr. Chen. Next, we have Delegate Bagnall, followed by Delegate Semple Hughes. Good afternoon, Delegate Bagnall.
Good afternoon. Thank you so much. And thank you for your presentation. I've had multiple conversations with our health officer, Dr. Kalyana Raman, who I really appreciate was on here. And I know part of our robust contact tracing and pop-up testing sites were for a longer term plan, a longer term initiative to get students back into the schools. So my question after seeing the presentation and the limited the limited testing sites in some of these jurisdictions that are already going to in-person learning is how robust are the contact tracing programs in those facilities? How much is the state working with the local health departments to make sure that those are set up so that we don't see another spike on the heels of in-person learning like we're seeing in other states?
Sure. Thank you very much for that. And, you know, to a certain extent, we have seen some of that happen in some of our universities where they were doing some testing and screening for individuals coming onto campus. And so some of the support that we've been able to offer in some of those situations is by extending the resources available to us through the NORC contract. So that's our contact tracing organization that we've contracted with, who help to make the phone calls and help make a connection with those cases and identify contacts in that way. They coordinate and you know, it's all put into a system that then the local health department, of course, has access to. And depending on the county and the jurisdiction, they have elected to either be the primary, so meaning they get the first information about who's positive in their jurisdiction and they make the initial contact, or they could be secondary, in which the state contractor does the initial contact, and if there are some additional issues or other additional follow-up that might be needed, then they're referred to the local health department. But in any situation where additional support is needed for contact tracing, we would have that discussion with the local health department and see what is needed, and also with, you know, the school system. I think that that's an important conversation to have in terms of how they may be working. And you know, I would say I would go back, you know, in pre-COVID when we talk about, you know, we have experienced various levels of outbreaks or infectious disease in schools around the state for other conditions, so non-COVID. And so we have experience already, and many schools and school systems have experience with working with local health departments to mitigate spread of infectious diseases with their school health teams and with others in partnership with the local health. So I would say that we continue to look at the contact tracing workforce and ways that we can augment it because we know that that is a critical component of our overall efforts as part of our road to recovery.
Thank you. Thank you, Madam Chair.
My pleasure. Thank you, Dr. Chen. Delegate Semple Hughes.
Thank you, Madam Chair, and thank
Pleasure.
everyone for being on this subcommittee work group or committee meeting today. We really appreciate the information. It's certainly valuable. I wanted to just highlight, you know, certainly many are probably all aware that the spikes have increased here on the Eastern Shore, namely Wicomico and certainly Worcester County as well. And with that being said, I appreciate the outreach efforts that came out immediately for the poultry industry. But in addition to the poultry industry, we still have, you know, increase in persons in the Haitian community and the Spanish community that work in farming and hospitality. So my first question is, how are you measuring the outreach that was done? How are you measuring the effectiveness? And then secondly, is the state working directly with the hospitality and the farming community, just as they have done with the poultry community as well?
So in terms of some of the impact of the work that was done earlier when we looked at the poultry associated outbreaks, it was really more in the community. I mean, the majority of the work was while we very much partnered with the industry side of things with the worker testing and such, there was a tremendous amount of testing also done in outreach and support, as Dr. Brathwaite outlined, in the communities, and that was done in partnership with local health departments, with the local hospitals, FQHCs, and community groups, so faith-based organizations in Wicomico County, for example, and also in Caroline and Dorchester counties. And so those are ongoing, you know, relationships that we have. I would say that there is, you know, we have a team at the health department who really spearheaded that effort early on when that became apparent as an issue. and they continue to work very closely with our partners in the Department of Commerce and Department of Agriculture to assure that concerns, issues that might arise from the industry side, that we remain on top of that. In addition, again, I can't emphasize enough how critical the eyes on the ground, the local health department and their staff are in making sure that those trends, that the connections, that the relationships that they have fostered over many years with these local organizations, with farmers and others, that those conversations continue to be had as well.
Okay. Any other questions from the committee? I don't see any in the chat room, but I do have a couple, if I may. And if there are any other questions from the committee, please let me know in the chat room. Thank you for your patience. So do you keep track of the clinical trial data available on racial and ethnic minorities? And I'm thinking about vaccine trials, and how are you educating our 6 million people in Maryland, especially the minority communities that often do not participate in these trials? What efforts are you taking, to communicate with the community? That's the first one.
That's an excellent question. I think that as I have participated in a few calls at the federal level with folks who are involved in Operation Warp Speed, which is the federal operation designed to bring COVID vaccine rapidly, safe and effective COVID vaccine to the marketplace. There are questions about, what about the representation among different racial and ethnic groups, among different age groups, gender, because we want to get as much information and understanding as we can from these vaccine trials that are currently ongoing, so that we have and have the best data possible to communicate with our population, our communities. So we are currently deep in the planning phases for, as all states are, to prepare for COVID vaccine. And a very, very critical component of that is obviously communication outreach, as you outlined, Madam Chair. And so that is where, to much extent, the group that I talked about earlier, whether it's the Hispanic outreach group, the convening of some of our community-based organizations and community leaders to help inform some of our prior communication strategies. Some of that will be part of our work going forward in the very near future, and certainly before, my goal would be certainly before the COVID vaccine comes to us. Right now, they're still being planned, and there's not a date certain, but that's absolutely critical, and we have put that really at the top of our list of items that we need to be very much focused on as part of our COVID vaccine planning.
That is important, as you know, in our communities of color, there's a lot of distrust, right? You have the Tuskegee and other experiments, and it's imperative to do that education. Can you please give the community, the Health and Government Operations community, committee, information on what is your plan, how you're going about it? You have to work with trusted sources, the churches, NAACP. You have to really do it at a granular level, very grassroots. So if you could please send us that, we really would appreciate it. The other question that I have is, there's a lot of data that is not available from looking at your charts, and there's a lot of data that is needed. Is there a discussion in the department and the governor's office to expand the role of CRISP and to make sure that we connect all the systems, because that is really imperative for us to look at the data and to drive our policy through the data. And what is your plan regarding that?
So absolutely, I think that as we rolled forward in the pandemic, collecting a lot of information, both at the what I consider sort of health-related data, some of which was presented today in terms of number of identified cases. We've also been looking at hospitalizations and deaths as well. When we look at the morbidity and mortality information, there's other operational information that we've been collecting, of course, in terms of testing and where tests have been deployed. So trying to pull all of that together, there is a group that has come together to really look at how we are looking at our data and to do additional data analytics on that information. So,
And what is that
work?
What is that group that has come together?
So under the group, I guess that, we have certainly our EPI team, so the infectious disease, epidemiology and outbreak response team within the public health services. We also, so they provide a lot of the information that's on our website, for example, because they oversee the NEDS surveillance system, and that is the system to which all reportable disease information goes to. So it really, a lot of it starts there. But there is data from hospitalizations and other data that the testing team, for example, collects. So I think the group is really pulling together, people from some of the different aspects of our response efforts to look at our data more collectively.
So I guess my question is, and if you could give to the committee, what do you propose coming up in this coming session regarding the IT and bringing all that data together? And are you meeting with CRISP? Because I think there is a role here for them and to expand what they do when you think about all the information at the, again, granular level, the city, the counties, the state, everything is being piecemeal. And I think that in order, like following up on Dr. Hill's suggestion and Simple Hughes and others, in order for us to have a true picture, you need to have that data and the connectivity. So if you can let us know, we really would appreciate it. We love to be able to work on that with you.
And Chris is absolutely at the table as well. Craig Bem and David Horrocks have been tremendous partners throughout this entire response effort.
And I guess my last question that I would like to ask is regarding, you can thank the governor for, issuing the proclamation regarding the Hispanic Heritage Month. But if you can ask the governor to do a bit more regarding this community that you said yourself today, the Hispanic case rate is 4 times higher than non-white Hispanic. The Black and brown communities are really being affected. When you discuss the Hispanic community, a lot of the Hispanic community do not qualify for certain programs, right? So they did not get a stimulus check. In addition, a lot of them that are working here legally and have a worker's permit legally and work and their employers pay taxes they were not able to file for unemployment because they need a social security number. The governor's program, which is wonderful, but regarding putting $30 million aside to help people with their back rent, he only used federal funds, did not use any state funds. So therefore, undocumented people that live here, that work, pay taxes, are not able to access that program. So they're left with no money from the federal government, they're left with no money from the state government, and there's no help for them at all. They're depending on nonprofits which are struggling. And the problem here for the Black and brown community is not just the access to healthcare, it is also how they live. I know families that are 9 and 10 families living together in Langley Park that are all positive. I know families that, they are essential workers. They don't make a lot of money. They take public transportation. So I want to know, what is the department and the governor plan to do in order to take care of this? Because these are social determinants of health. And, we're the health committee, we propose a lot of these policies, right? I mean, a lot of us delegates and senators, but from the department, are you going to play a bigger role regarding all those issues?
So, thank you for that question and also the perspective there. We have been, of course, very acutely aware, as we've seen not only for our own families and friends and such, the impact of the pandemic on families big and small, that it is something that we absolutely recognize. This pandemic response has, it goes well beyond the work of the Maryland Department of Health, and so we look to our partners who have been very engaged with other, in terms of other state agencies as well, who have been also very critical in much of the, in managing and mitigating a lot of the impact of the pandemic on these communities and these families, so including our partners at the Department of Human Services, Department of Housing and Community Development, and Commerce, and others who work together with us to mitigate the impacts, because this really, this pandemic has not left any corner of Maryland untouched. So that is an ongoing conversation, bring that back to our group as we look at our efforts going forward.
I suggest, if I may respectfully, that you put together a task force of all these different departments and to come up with some solutions, especially as we're getting ready for next session as well, because it's really important. And my last question that I have is, are you planning to beef up the Maryland Department of the Office of Minority Health and Health Disparities? Are you going to hire more people, give it more money, bring more people that are progressive and creative, to work with trusted partners? Because it really, as I look at other departments of minority health and health disparity, they're so robust. There's so much more. Are we looking at expanding and giving Dr. Noel Braithwaite some more staffing and money and support?
So I don't know if Dr. Braithwaite would like to take that question. I think that it is, as we look at how we continue to respond, there are a number of different federal sources that we have deployed to the Office of Minority Health and Health Disparities to support efforts around the state. And as the opportunity arises and as the need is certainly there, we are certainly looking to make that continue to happen. So, and it of course depends on ongoing availability of resources and funds and the priorities as it speaks to vaccines and contact tracing and others. And so that they are integrated into the work that we're doing across the board.
Thank you. But it needs to be not just now because we're reacting. It needs to be something that we leave permanently, so it's consistent throughout the years, because we're dealing with generational poverty. And many people now, they have lost their jobs. They can't access their unemployment because it's been such a mess. They can't make a living. They're gonna be like this for decades to come. So we need to beef up that office. It needs to have more people. It needs to come up with some solutions, with some priorities. I mean, we as delegates come up with, like this past session, I put in the bill that requires, implicit bias training for maternal health. We need to come up with some type of solutions like that as well, and others. So I want us to work together as the subcommittee that deals with this issue. And I know my chair, which I'm extremely grateful, and the speaker has given me, actually a lot of leeway to deal with this issue, and the subcommittee members that do the work. We want to work with you. So I think that it is imperative to think about not just temporarily, but the future as well. Very important. Okay, you can consider us as a partner.
If I can respond to your question.
Yes.
We continue to fund non-COVID responses. The model grantees, we have for fiscal year 21, we are funding 21 grantees which is an increase from fiscal year 20 from 15 to 21. And that's for 2 years. And they're dealing with issues beyond COVID, issues such as diabetes and obesity and cancer, even issues dealing with maternal child health. And we are also going to be employing 2 other positions within the office, which would deal with COVID-specific activities. And we have launched the contact tracing unit, our epidemiologists, and also want to do messaging within the context of the contact tracing. So we are partnering with contact tracing unit with our resources. We also have a grant writer, and that grant writer is tasked with looking at extra resources. And we applied for a Pfizer grant recently, and that Pfizer grant is to do some cancer prevention. And in addition to that, we are doing some breastfeeding, which is just another kind of program initiative from our office. So we are not only looking at state funding, but also at funding from the federal government and funding from the private sector to expand our reach in the community, also to expand our influences. We do have some priorities that are funded through the MODA program, and we'll continue to explore in collaboration with the local health departments, funding related to health equity. We're glad that the local health departments are identifying health equity coordinators. And we are hoping that over the next 2 years or so, with the health equity coordinators, we would be able to put together for the state a health equity plan. I think that that's something which is on our calendar as we continue to expand our reach into the community and collaboration with the local health departments, and also collaboration with the other entities within the Department of Health.
Dr. Braithwaite, can you tell the committee what is the amount of money for the fiscal year, as you said, 2021 for grants? How much is that?
For the MODA grantees, it's approximately about 600,000 for the 21 MODA grantees.
$600,000?
Yes.
Okay, so my point here is that we need more than that, and that instead of depending on outside grants and the federal government, that the state, the governor needs to, the department, make it a priority to fund it, to give more money, for your office, because it's needed. And we can see clearly from the health disparities that this is here to stay with us for a long time. Okay, so we want that your office to be beefed up, to have more resources as well. Are there any other questions from the committee? I don't see any on the chat. So I want to thank everyone that came. The legislature's COVID-19 response work group, which actually has a meeting this coming Wednesday at 10 o'clock, will continue to address a variety of issues related to the topics and jurisdiction of this and other committees. As of now, and at the direction of the work group, the ACO committee has scheduled a series of full committee under the leadership of our chair, Pendergrass, and subcommittee briefings. For the public, please monitor the ACO committee hearing schedule on the Maryland General Assembly website for updates. For committee members, I thank you so much for your time and for your questions, and I hope you stayed healthy. You will receive an updated list of meetings and dates via email from the committee staff. I want to thank the committee staff, Dylan and Aaron and OIS, for your wonderful time and for making it easy for us. And for all of you that took time today to listen to us, thank you so much for caring. And please stay well, okay? And stay healthy. Have a blessed day. Take care. Bye.